Are you able to hear me?
Yes, sir.
Diagnosis is one of the chapter which is a part of case history, and this has been covered extensively in your third year BDS as well for all the subjects. If not, it will be covered for again obviously all the clinical subjects, that is conservative, endo, perio, pedo. Everyone has their own method of case history, but the point is. Uh, the maximum patients that come into your clinic will always be the one who are having caries and obviously pain in their tooth, and this is where a conservative and endo case history should be the primary basis of your all case histories, upon which other case histories should be superimposed. For example, the caries, always the caries status should be seen, because patients will not complain mostly of, let's say, I have bleeding gums. Patients will not complain of malaligned teeth, but they will surely complain of pain. And whether you are a good practitioner or not will always be, uh, it will be decided upon how you make the diagnosis correctly, because if your diagnosis is correct, your treatment plan will be correct and the patients will be pain free. So we'll go ahead straight away to the next. These are the things that we'll be covering. So diagnosis is nothing but the inference. You ask patient something, you get the knowledge, and you come to a conclusion. That is case history and diagnosis, nothing else. So what you come initially is the provisional diagnosis, upon which you do certain investigations, and then you come onto a final diagnosis. This is nothing else is there in the chapter which you have not heard before. So we'll not go into this. Will be what exactly do you ask the patient when he walks into your clinic is the personal information aside. You ask the name, age, sex, and the address of the patient. The most important thing that you ask is the past medical history. Why do you ask past medical history? Because there are a number of medical conditions and diseases which will have its own implication on your treatment plan, the medications and other things. For example, a patient having high blood pressure, you cannot give an adrenaline based local anesthesia. You have to give a plain local anesthesia. If the patient is suffering from myocardial infarction, you have to defer all the treatments. If the patient is pregnant, you cannot do certain treatment procedures in the first and the third trimesters. So this is the knowledge that you have to keep into consideration. Even epilepsy, for that matter, you cannot use too much of a local anesthesia because patients may develop epileptic fits. So you have to ask patient past medical history for these purposes. Then you have to ask the patient about past dental history, because past dental history is very important to understand. Let's say a patient is having a pain in a particular tooth, and you have to ask what exactly was done by whom. That is how you will come to know patient's own expectations from that treatment, and whether it was done correctly or not. After practicing for, let's say, 5 years, you will come to know who are working in your area. So those patients will the patients will circulate between you 5 or 10 dentists, and then you will come to know whether the number one dentist was correctly working or not. And this will give you a clear picture whether a particular treatment procedure has to be done or not. So past dental history is also very important. Next, what you ask the patient is the chief complaint of the patient. Now, chief complaint of the patient is always asked in the patient, or written down in the patient's own words. Now, why do you do this? Because you have to be medico-legally correct. And secondly, let's say the patient says, I have pain in the upper right posterior region. This is what you write in oral diagnosis case history also. Upper right posterior region. Now, if by looking into the patient's mouth, you write down no, patient has pain only in the 1/6. What happens in an institutional setting like ours is the patient from OD will go to conservative, and the conservative person who is looking into the patient's mouth will only look at 1/6. He will not look at the other uh, things like 1/7. He will not look at 1/7. He will not look at 1/5, 1/4. He will not look at the gums. He will not look at the DMJ. Nothing. Why? Because the patient's chief complaint was interpreted by the doctor, and it was written as not pain in the upper right region, but it was written as the pain in one section. That is why, to avoid this bias, we call it as a bias. So avoid this bias or partiality, we write down the patient's chief complaint in their own words. This is the reason. And second is obviously medical legal reasons that you write down patient's chief complaint in their own words. Next comes history of present illness. Now, if you are able to write down, please write down. I'll be just telling you certain questions that you are supposed to ask compulsorily to the patient in case that the patient complains of pain. The first thing that you ask to the patient is about the origin of the pain. This all things are not written in this PPT. I'm just telling you of the textbook. The first thing that you ask to the patient when the patient is having pain is the origin of the pain, how it started, whether it was a sudden onset pain or it gradually increased from 0 to 100. This is what you ask to the patient. Second, you ask about the duration of the pain. So if the patient is having pain at 6 o'clock in the morning, so for how much time that pain is staying, whether it is staying for a 1 second, whether it is staying for 5 minutes, whether it is staying for 1 hour or something like this. So this is the duration of the pain. And the third is the progress of the pain. That means what is the status of the pain at this particular point of time. Are you able to hear me?
Yes, sir.
Okay. So these are the first three questions. You have to jot them down manually. Second thing that you will be asking is whether the pain is localized or diffuse. Localized pain will stay in the same area. We'll take an example of a tooth, for example, 4-6. If the patient is complaining that I have pain in the lower right posterior region, that the pain will always be localized in that particular segment of teeth only. It will not spread anywhere. It is not diffuse. Diffuse in the sense it is not spreading anywhere else. This is very different as compared to radiating pain and referred pain. Now, radiating pain is the one, for example, let's take the example of myocardial infarction, whereby the pain radiates to the left side of the patient's body or the patient's jaw or the left side of the shoulder. But referred pain is the one in which the pain goes to an area where the diagnosis becomes difficult. For example, the lower tooth pain can get referred to any other tooth in that section, or it can get referred to the temple region because the nerve supply of mandibular nerve is there also. So you have to take into consideration all this. So you have to ask whether the pain is localized or diffused, whether the pain is referred or radiated. Referred, for example, if the patient is having pain in the lower right posterior region, after making a provisional diagnosis, you come to know that 4-6 is having pain, but patient says that that tooth is not paining. I have pain in the sinus. I have a sinusitis. I have a pain in the TMJ. That is an example of a referred pain. That means the place where the pain originated is not paining, but something else is paining is called as a referred pain. But the pain in which the place of origin is also paining, and the area where the pain is spreading is also paining. Like the myocardial infarction pain is called as a radiating pain. Localized pain is the one in which the pain is there only in a particular area. Diffuse is the one where the pain is spreading to different areas. Have you understood this? This is any answer? Yes or no?
Yes, sir.
I'm just hearing only one voice. Any which ways. We'll go to the next question. First was origin, duration,
Yes, sir.
progress. Next is localized, diffuse, referred, or radiating. You have to ask whether the pain is continuous or not continuous, whether the pain is occasional or frequent, whether the pain is intermittent, right? So these are other four questions. First is continuous, intermittent, occasional, or frequent. These are the other set of questions that you have to ask. Also, you have to ask what are the aggravating factors, what are the relieving factors. Now, what is aggravating factors? Aggravating factors are cold foodstuffs, cold drinks, hot foodstuffs, hot drinks like soup. These can aggravate pain. And then if the pain happens because of these aggravating factors, what are the relieving factors the patient is? Some patients apply ice, some patients apply, if the pain starts because of cold, it will get relieved because of hot drinks. If the patient's having pain because of hot drinks like soup, the patient will get relief because of ice. So these are the things that you have to ask the patient. Aggravating and relieving factors. You have to ask whether the patient is having pain at night. So this is one of the very important question. Whether the patient is having pain at night, and if the pain starts automatically, or as the textbook says, the pain starts spontaneously. That means without any stimulus. And if the patient says yes to this, that yes, I have pain at night, I have spontaneous pain, the answer is very specific. That means the disease and the diagnosis is also very specific, and the treatment is also very specific. I don't know whether you know this name. The answer to this particular symptom is uh, acute irreversible pulpitis, and the treatment is root canal treatment. So once you ask these many questions to the patient, you will automatically come on to a provisional diagnosis. But these questions have to be asked to the every patient who are coming to you with certain pain. If the patient is answering no to everything, then we'll go ahead with the examination and investigations and other things. But these questions, this set of questions, origin, duration, progress, localized, diffuse, continuous, intermittent, occasional, frequent, do you have a spontaneous pain? Do you have pain at night? Do you have pain at bending down or sleeping? Whether the pain is referred or radiating? What are the aggravating, relieving factors? So these are the questions you are supposed to ask in history of present illness. Otherwise, your case history is not complete. In fact, you are supposed to write down your history of present illness in a particular, like a story, but based on these questions. Once this particular set of questions, that is history of present illness, is asked, you are supposed to go to the next section of the case history. That is, you are supposed to go to the examination section, the intraoral examination, and obviously extraoral examination also if there is a swelling. In extraoral examination, obviously you will see for swelling, and you will see for TMJ pain, you will see for the lymph nodes. All of you know how to palpate the lymph nodes. All of you know how to check for the TMJ clicking and any kind of a trismus with the TMJ. Swelling, you will have to see whether there is a three-finger test for fluctuation of a swelling. You will have to see for the facial symmetry in case of a swelling, and you have to see whether the swelling is diffused, the localized, or it is spreading somewhere else. You'll have to see the consistency of the bone if there is a swelling from outside of the face, the consistency of the bone from inside of the intraorally will be checked in intraoral examinations. Once this extraoral palpation and examination is done, we will go on to the intraoral examination, whereby the first things that you will check will always be in the area of the chief complaint, and then you will go to the other areas. Particularly in India, this is very important, because if you start checking in somewhere else, because it is written in the textbook that you will start in the first quadrant, you cannot do that in patients, because patient will complain that you are unnecessarily troubling them. So always start the intraoral examination in the area of the chief complaint, nowhere else, and start checking the tooth. First is a visual examination, then is the tactile examination, and then there is a radiographic examination. In case of the visual examination, you have to see for whether the patient is having any caries back. Okay.
सर तेरह सर तेरह तो पूरा तेरह वर्ष
Save करा. In intraoral examination, particularly, there are three things. First is visual examination, tactile and radiographic. In visual examination, you will see for whether the tooth is carious, whether the tooth is having any signs of trauma, is there any adhesion, abrasion, abfraction, is there any amount of cracks present, is the gingiva receded. These are visual examinations. You don't require a mouth mirror, obviously, you require a mouth mirror to retract the cheek, but you don't use a straight probe. You just see how the tooth looks like, and then you go for tactile examination. In tactile examination, you will always check for three things. First is color, contour, and consistency. This is given in your gross term, so you don't have to worry about this. Color, contour, and consistency in the sense, what is the color of the tooth in question, all the teeth in question. I mean, a particular area or a quadrant will have 8 teeth. So all the 8 teeth you will check for visual, tactile, and radiographic. In tactile, you will see color of all the teeth in that quadrant or in that area. You will see the consistency. Consistency in the sense, if it is carious, it will be softer. If it is related to trauma, it will not be softer. You will see for contour of the tooth. If it is traumatic injury has happened, then the tooth will be fractured. The contour is changed. If it is carious, contour will be changed. So you have to look for all these things. In tactile, you have to use a curved probe or a straight probe to check what exactly is wrong with the tooth. And next comes the radiographic examination of that particular or those particular teeth in that particular region. That means you don't have to take 8 radiographs. There is a sequence of radiographs that you have to take for all the 8 teeth. But by that particular time, by the time that you reach radiographic examination, your provisional diagnosis is already ready, and then you go ahead with the radiographic examination. You cannot take 8 radiographs for 8 teeth in a particular quadrant. Right? Just keep this in mind. Next thing, after radiographic examination, you will come on to the palpation, percussion, mobility, and depressibility. These are three tests which are taken together. First is palpation. How do you palpate? You will hold one finger on the buccal side of the bone, and you will hold the other finger, that is your thumb, on the inner side of the bone, and you will palpate. Next, you will do bilateral palpation also. That means one finger on the right side of, let's say, lower jaw, and the other finger will be on the left side of the lower jaw. Same for upper jaw also. If you are palpating the upper jaw, you will always keep one finger on the right side of the upper jaw and the left one finger on the left side. Right? It doesn't make sense when I'm speaking, but once you start doing it, you'll come to know this is the palpation. You will see for the consistency of the bone. You will see hardness of the bone. You will see whether, let's say, there is a cyst formation in the bone will have a different consistency. If there is a tumor, the bone will not be there, obviously. So you have to see all this during palpation. You will palpate the next case is the percussion. Uh, in percussion, there is a particular method that has been taught to you, let's say in oral diagnosis or any other department. You have seen your seniors working, that is, you take the blunt end of the instrument and start hammering the tooth. This is not percussion. In percussion, you will have to percuss means hit the tooth. It's not hitting the tooth, you have to press the tooth. If you start hitting every tooth will have pain on percussion. You have to do a, uh pressing of the tooth with the blunt end of the instrument, and you'll have to start doing this from the tooth which is not giving any symptom at all, which looks very normal. So start with premolar, for example, then go on to the second premolar, then go to the first molar, then go to second molar, or you can start in the reverse direction also, but start with the tooth which is harmless, which looks very innocent, and start with that tooth. Then only patient will come to know what is a normal percussion and what is a painful percussion, and that is how you do a percussion test. Finally, you all know what is mobility and depressibility. There are grade 1 mobility, grade 2 and grade 3 mobility. You have to check for depressibility in case of abscesses, cysts and tumors, and that is how you check for mobility and depressibility. You just use two blunt end of any instruments, that is your straight probe and your mirror, and you start moving the tooth. Grade 1 obviously is less than 2 millimeter of mobility in either direction, and that is buccolingually and mesodistally. Grade 2 is more than 2 millimeters, and finally The grade 3 is not only it is mobile more than 2 millimeters in buccal and lingual, but also it is mobile in up and down direction in the socket. So this is grade 3 mobility. Why do you check mobility? It is a perio thing, but still, if the tooth is not going to stay in the mouth for a particular period, then why to do any restoration and root canal on that? Just go. Let's ask that patient to go for extraction. This is why you check for uh, the mobility and depressivity. Why do you do percussion? Because you want to know whether there is any periapical inflammation or not. That means that if the patient is having periapical inflammation or abscess or cyst or granuloma, patient will give you pain on percussion response, particularly if it is an acute disease. The next things that you have to do is about the vitality testing of the patient, pulp vitality testing. Now what exactly is the meaning of vitality is, you all have seen or must have heard that you do cold testing, you do hot testing. Now in cold testing you apply cold to the patient's tooth, and you get a response from the patient. So vitality, as per se, whatever test that we are doing are based on nerve responses, but ideally vitality of a particular tissue is dependent on the blood supply of that particular tissue. So in the next class we'll be covering the vitality of the pulp in detail, because it is a question which is asked in university exams also. All that we have discussed today is for your clinical practice. How do you perform as a diagnostician, as a clinician? But from tomorrow what we'll be discussing will be the vitality testing of the pulp. And what I will suggest is, whatever I have discussed till now, you can go ahead and read in gross